Yeah, we're still doing that. Yeah.
So I think we're going to get started. I want to introduce our speaker tonight. Oh, yeah. Dr. Elisabeth Dellon, and she's from Minnesota, and she actually did her residency in Boston, which is where my girls were being seen with one of the doctors that she was studying under, Dr. Dorkin.
Oh, wow, yeah.
So anyway, and then so I remember seeing you there, and then you went down to UNC for her fellowship. So, but she's graciously agreed to present some highlights from the conference for all of us, and I don't know if you want to present and take questions afterwards, or how you want to handle that. But.
Yeah, no, however you guys want to do it. I would love for you to kind of speak up if you have questions or if you have comments about things or experiences that you want to share. I have kind of a lot of information that I brought back that I will try to cover, and we can sort of get through whatever works best. But definitely speak up, and we can just sort of do this as it works for all of you. And I apologize to people on the webcam if I make funny faces when I talk. That's just the way that I am. Those of you who work with me know I make a lot of funny faces. So let's go ahead with the first slide. Sorry, the next slide, if you can. It's not working. Oh no.
Yes, I see.
We're just not seeing you. We're seeing this camera here.
Mouse isn't mousing. Okay. How are the babies? Get a present some challenges, huh? You want? I can have my laptop if that will work. Or is it too? Oh, you probably have your.
Of course,
Everything.
Let's take a minute while we're working on this. I got to walk around and say hi and meet many of you who I don't know, but not totally everybody. And I thought, many of you have met each other, or either in person or on social media or lots of different ways. But it'd be kind of fun if we could go around the room and just introduce yourselves a little bit. Would that be okay? You want to start with
people on the call?
And there are people on the call that can do that too. That's right. Do you want to start, Mike?
Sure. I'm Mike Rock. I have a 17-year-old daughter, Angelica, And my wife, Mary Beth, is right there.
I'm Michelle. I have a daughter who's about 5 years old. I also have newborn twins. But I have other kids. Hi, I'm Kimberly Houston, and this is my husband. Let you introduce yourself. We have 3 girls, ages 7 and 3. Elise Dellon. I have 3 kids. It's just my youngest, Jackson, is 18, freshman in college. Yeah.
I'm sorry. That's my phone. That's the school. Great. Worry about those school calls. They can't be closed again.
I'm Kat, and I have a 5-year-old girl and almost 2-year-old son.
I'm Amy. I have Allie, who's 17 with CF, and I have a 14-year-old daughter, Betsy, who's not having CF.
I am Jill. I have 2 daughters. Eva is 14, has CF, and
You got it.
I am Annetta. I have a 9-month-old with CF, and this is my mom, Donna.
I have 2 daughters with CF. I think my husband. Wait, they can't get the video to work, so they're calling in. But we have 2 daughters with CF, ages 19.
Mark Serpian. I don't have a CF connection. I serve on the board, the Carolinas chapter. For a while on fundraising and other board activities.
And I'm Lynn McGibbon. I'm a social worker in the CF clinic, and I know most of you.
And I did neglect to thank the because they're hosting this event. We're very grateful.
I don't know if there's anybody
on the,
from home.
From home. We'll be able to hear them, hopefully.
Maybe they're just following. Go to meeting.
Okay.
So there's a Gwen, Jacqueline Morgan, and Teresa Parker. Looks like maybe one other caller who's not identified themselves.
This is Timothy Weber. I'm dialed in. I can hear you all.
Hey. Watch out. All right. Well, it's great to meet all of you and to see those of you who have met before and have the opportunity to work with many of your wonderful kids. I think we're struggling a little bit here with AB. Oh, maybe we can we'll have to see. But I can tell you a little bit about myself because I'm new to some of you guys. So I'm a pediatric pulmonologist, and oh my gosh, okay, that was going to be what we're going to talk about. We can go ahead. Can do if we can. Maybe. Going to the next one. Next one? Yeah. You just did that. Go to the next slide too. I trained in Boston in internal medicine and pediatrics, and then came to UNC for pediatric pulmonary training like a million years ago already. And CF has always been kind of my primary clinical interest. I had the great pleasure of working in our adult CF clinics for many years, and really, really enjoyed that a lot. My internal medicine background kind of allowed me to do that for a while. And I also do the medical care for kids who are waiting for lung transplants or who have lung transplants. My other kind of half of my job is as a pediatric palliative care physician, and I don't know how many of you guys are familiar with palliative care, but it's basically medical care that's focused on quality of life for people who are living with serious illness. And I'm the director of our consult service in the Children's Hospital. And we take care of kids with a really wide variety of serious medical conditions. Sometimes CF, not often CF, but sometimes, but many different chronic conditions. I'm also an educator. I do a lot of teaching for medical students, residents, fellows, lots of people from different disciplines. We work really closely, of course. Our CF care model with people in our on our care team who have lots of different backgrounds and training. It is actually a model that's used in a lot of different areas in healthcare, and so certainly with palliative care as well. We do a lot of work in teaching with people who train in other disciplines. And I do research kind of at the intersection of cystic fibrosis, palliative care, and long-term medicine. And if you can advance, I want to also introduce my other big job, which is my babies. So Vivian on the left is 8, and she's a second grader, and Hannah on the right is 11 and has ventured into middle school this year. And it has been an awesome adventure, actually, so far. So, and they were all really excited to hear what I was doing tonight because they thought it was a good idea to come and meet with parents whose kids have CF. They've learned a lot about CF over the years. They're very passionate about supporting my work, which is really nice. So if you can go to the next slide, I'm just realizing I hope I don't have much animation. I don't think I do. Well, let's talk about some conference highlights. So first of all, you can go ahead, the CF registry report. So every year at the conference, we kind of get like the last year's registry report, and there was a sneak peek with some information that went out in one of the newsletters recently, but I just wanted to hit a couple of the highlights that I think are things that, are themes that were kind of brought out at the conference, and there are going to be some pictures that I didn't give credit to that come from this kind of throughout the talk. So if you want to go to the next slide. First of all, every year we get an update on lung function, and so they reported this year on median FEV1, or the kind of main measure of lung function predicted by age, looking at what things were like 20 years ago and what were like in 2017. So the median FEV1 for 10-year-olds in 1997 was 88 and has increased to 97 as of 2017. The middle picture for 18-year-olds was 69% in 1997 and increased quite significantly to 85% in 2017. And for 30-year-olds was 50% back then and 61% right now. So really exciting to see this. If you can go to the next slide. Pulmonary therapies are things that we're all kind of really interested and excited about, kind of new and developing therapies, but sort of an update on where we are with what people are doing to maintain their health. On the left, people with CF who take the kind of standard medications, inhaled medications to support airway clearance and treat infection. About a third of people actually take 3 or more inhaled medications to maintain their health. And on the right is a figure that shows the number of people with CF during the past year who were treated with IV antibiotics for pulmonary exacerbation. And it was 24% of children and 43% of adults. And there aren't comparisons to the past that are offered in these figures, but the percentage is actually going down with time, as we would expect as treatments continue to improve. Go to the next slide. Survival, which is something that we're all obviously very focused on. As you know, that figure has been just really improving. That curve has been going up and up and up over time. And if you look at this figure here in 5-year increments, you can see that the median predicted survival for people with CF born between 2013 and 2017 is 44 years. There's so much individual variability, and this is a predictive model that we never know what to expect for an individual person, but it's really exciting to see that ongoing increase with time. Now adults are 53.5% of the U.S. population living with CF, and they projected that in 20 years, adults will actually make up 68% of the U.S. population living with CF just because of improved survival, which is really exciting. They spent a lot of time at the conference kind of focusing on this and thinking about what will life be like, right, for people who are living as adults with CF 20 years from now as opposed to now, and thinking about sort of shifting those categories of people who have severe lung disease down to more moderate lung disease, and those who have moderate lung disease down to milder lung disease with time, so that our population should be getting older and healthier as they get older.
Excuse me, last year Preston said that the median age had moved to 47, and then now I see 44.
This is the point, that's the point estimate for last year. Sorry, 44 is the conglomerate estimate of that 5-year period.
Okay.
So you're right. Actually, it is, I think 49 as of last year. So this is, thank you, I should have clarified that. This is in 5-year increments. The survival data are really hard to interpret, and it's a projection of the average, right? Recognizing that there's a wide range. The registry actually contains data on an 89-year-old with CF currently, so that's pretty exciting to see too. So they used to report annual data on a figure with, many, many, many years of points, and now they clump it into clusters of 5 years for the kind of bigger reporting.
With the current medicine,
That's the predicted based on currently available therapies, right? Okay. And there's, when the registry report is published, there are kind of like a few pages with information on survival statistics, and they try to explain it in a really clear way, and I think it's hard to grasp. If you're a very mathematically oriented person or know a lot about statistics, it's much more graspable, but some of us have to think really hard about it in order to be able to process it. So if you have any questions about that, make sure you ask, because we're happy to talk through it with you guys. Thinking about adulthood, I just think this is really cool. So kind of what are the characteristics of adults who are living with CF right now? So over half of adults with CF have full-time or part-time jobs. 43% of adults report being married or living together, and that's actually a little bit higher than the sort of national statistics overall. And 31% of adults with CF have a college degree, which is also higher than the national statistics for people adults of all ages. If we looked at the CF-specific age range also, or a distribution, we might find that this is a little more on par, but I thought that was really exciting to see. Go ahead to the next slide. So I want to talk about therapies. This is a big thing that everybody's really, of course, focused on, right, is therapeutic development. This is kind of hard to see, but I wanted to point out that thinking about studying therapies is a stepwise process that's been, it's universally applied across therapeutics development for any condition. For CF, there's sort of become, with the Therapeutics Development Network, a really nicely protocolized way of because we're looking often at the same outcomes, we need about the same number of people participating in studies. So this is just kind of goes through like what the process is. So the different phases of a clinical trial are there on the left, 1, 2, 3, and 4, with the FDA approval process in the middle, and then kind of what that entails. So drugs or therapies that are in phase 1 trials are like a cool compound that's been developed that we think might be helpful. It's a short study in healthy volunteers that look at things like, is it safe? How is it metabolized by the body, and what are the side effects? And if it looks like, hey, this is something that might actually not harm people, and it might have a good mechanism in CF, then they go to a phase 2 study where it's a reasonable number, but fairly small number still, of people with CF who meet study criteria for a relatively short period, usually 3 to 12 months, looking at also safety, but also looking at efficacy. Does it actually do what we're hoping that it will do? And figuring out the right dose. Okay, so that's kind of that second step. Usually they'll look at different dosing regimens in different participants, or have the same participants start with one dose and change to another dose and kind of look at those effects. Once a drug gets through that stage, if it's found that there looks like there's benefit and it's well tolerated, it goes to a phase 3 clinical trial. And these are bigger studies, usually at multiple centers, usually for a period of 6 to 12 months, that look at the selected dose based on the previous studies in a larger number of people, usually versus placebo or versus a standard therapy, so versus something that we wouldn't expect to have an effect. And it looks at effectiveness or efficacy, it looks at safety, and of course we want to think about would the benefit of this therapy outweigh the risk. So if a drug gets through that phase and we think it's a good thing, then there's an application made to the Food and Drug Administration for approval. And because CF is a rare disease, that approval process is expedited. And some of you are very familiar with this if you look at current research that's going on. So for example, our CFTR modulators that we'll talk about have been gone through a very rapid FDA approval process versus drugs that are new, that are approved for more common conditions when there are already good therapies in existence, may take years to get through the FDA. This is a process that's much, much shorter. And then after it's been approved and it's available for use by the public, some people enroll in phase 4 studies where we really look at kind of the real world applications. So if we're not strictly monitoring you and having very strict stipulations about what you do when, and we just let you take this medication or this therapy the way that you would do it in your real life, and we collect information and watch you over time. What does it look like in the real world? Okay, and some of you, your kids may have participated in some of these studies. So I just wanted to review that because some of the therapy updates are kind of, it's relevant, like where we are, right, in this process. Okay, does anybody have any questions about that? This figure is also available in the kind of registry data summary that's just available on cff.org. And so if you ever like are approached about a study and you want to kind of look at where it is in that process, that's a good way to kind of refresh your memory about this. Okay, let me go ahead. The CFTR modulators, and again, this is not for you to look at the details of this, it was nice pictures that they offer. The know your mutations piece of having CF, and we have these posters up in the clinic, and this information is available online, has never been more important than it is now, right? Because the therapies that are being studied and some therapies that are now available are applicable to people with certain gene mutations that lead to CF. So on the right, here are sort of the kind of therapies that already have been approved, ivacaftor or Kalydeco, which is for about 6% of the population who has a certain type of mutation where the protein is made and it gets to the surface of the cell, but it just doesn't open and function properly. Lumacaftor, ivacaftor, which is Orkambi, and tezacaftor, ivacaftor, which is Symdeco or Symdeco. I still don't know how we're supposed to say it. Depends on whether you want to sound like you're from New Orleans. These drugs are for people with 2 copies of Delta S 508, which is the most common gene mutation in CF. It's also one that is of the most complicated in terms of how to correct it. If you can hit the next, I think, slide. Oh, sorry, go back one more. Sorry, Delta S 508. It's class 2. So the protein is created, but it doesn't fold correctly in a way that it can get to the cell surface. So if you fix that problem, you get it to the cell surface, you still have to open it. So it requires multiple drugs to correct it. We're going to actually talk about a little bit of follow-up data from these, and some of your kids may be taking these medications, but we're going to focus a little bit more on what everybody's been really excited about, which is triple combination therapy. So if you want to go ahead to the next slide. First of all, just kind of where are we with this? This is again from the registry report summary. By year, in 2013, when ivacaftor Kalydeco was approved, about 4% of people, because it was only approved in adults at that time, or 12 and up, sorry, at that time, had a modulator that they could take. In 2015, when Orkambi was approved, it became 38%, and then with Orkambi being approved down to lower age range, it became 53%. This doesn't include now, since Symdeco has been approved, maybe people who wouldn't have chosen to take Orkambi because of drug interactions or other problems would now be eligible for this. It also doesn't include the 2 to 5-year-old age range because the drug Orkambi was approved down to age 2 a few months ago. So presumably that's a little higher than 53% now. They also look at of the people who could be taking these drugs, and we don't have Symdeco or which is ivacaftor and tezacaftor on here because these data are from 2017 and it was approved in 2018. But about 63% of people who were eligible for lumacaftor, ivacaftor, or Orkambi were taking it, and about 59% of people who were eligible for ivacaftor were taking it. And there are lots of reasons why people may not be taking it. Access hopefully is not one of those issues because, as many of you know, the Gates Foundation has worked really hard to ensure access to these drugs. Some of it's choice, some of it's wanting to see the real world experience to make a decision about treating, and for some people there are medical reasons that they can't take these medications. If you want to go ahead to the next slide. Oh, sorry, next one. Stuff that back in. Oh, yes, to highlight these guys. So if you can go ahead to the next one. I'm sorry, has a few, just so you can hit it once. So triple combination therapy is what we're all really, really excited about. And there was a lot of information presented at the conference. There's a lot of information about this online. So this is tezacaftor, ivacaftor combined, or Symdeco, combined with another corrector therapy. And there are 2 different candidate drugs right now. Vertex makes those drugs, 445 and 659. These are for people who have at least one copy of delta F508. Okay, so that's 90% of people with CF. As of right now, we know from that there are two studies going, or from two studies, phase 2 studies of adults with either 2 copies of delta F508 or 1 copy and another mutation to investigate safety and tolerability, and change in lung function showed a very rapid improvement in FEV1 on the order of like 14%, which is drastically more than the other currently available medications. A decrease in the sweat chloride concentration, that test that we do that demonstrates that somebody has cystic fibrosis, and importantly, improvement in quality of life, so better symptoms and function, and all of the things that, like being able to do the things that you want to do. Both of those drugs were really well tolerated, and right now they're enrolling in phase 3 studies to basically look at which of those drugs is better, with the goal of actually in 2019 having an answer to that question and submitting to the FDA for approval. So a super, super exciting time. Some of you are very much in the know on these things. Some of you, it may be totally new information, but I want to make sure that you have the opportunity to ask questions about this, if you have them. This is where a lot of people have been turning their attention. Hi, nice to see you.
What's the difference between 445 and 659?
They're just different compounds. And so they basically, when they were tested, they looked, the effects looked very similar and the tolerability was very similar. So they're basically looking to see which one.
I mean, that's it.
Phase 3 is better. Yeah. Yeah. So it's really pretty cool.
Why do they only want to pick one?
I think because if there's one that's superior, everybody would prescribe it, right? So truly, we may be in a situation where, at least for our 12 and older population, because that's the age range that's included in the study, we would be potentially switching anybody who's been on Orkambi or Symdeko to one of these drugs in the next, in a year or a little more than a year from now. And it would be a very different conversation for people who are eligible for those drugs that have chosen not to take one. Because as long as the information that we get from the clinical trials now look as good as those earlier studies do, because it has a much more dramatic effect. So it would be probably an easier decision, and actually, importantly, looks like will probably be better tolerated. We've had some challenges with, especially Orkambi. Other questions?
Yeah, so when is it likely for FDA approval? Is that the middle of next year or the latter part of next year?
Studies are enrolling, and they will wrap at some point in spring to summer, and I believe. And then they would submit it won't be. It'll be potentially fall. They would be submitting to the FDA as early as the end of 2019, a little over a year from now.
And then the FDA approval, that's fast-tracked?
Fast-tracked, so it could be, they were saying it could be late 2019. They anticipate probably a little bit later than that, just because of the logistics of churning through all of the information from all the people who are participating. And of course, as we get more of these drugs to study, there's a smaller pool of participants, right? So there are a lot of people that were already taking a modulator who had to kind of be transitioned onto study drugs. And so that also adds a little bit of kind of time to that, those studies. So it may well be really around the corner, which is very, very exciting. Yeah. So when we say up to 90% would be eligible, of course, we have to remember that they still will have to study these drugs in younger patients before they can have access to it, right? They have to figure out the right dose and figure out whether people tolerate it and what the effects are.
Just one more thing. What would be the effect of this drug as opposed to Kalydeco?
So comparatively, it looks like actually the improvement in lung function is more on the order of Kalydeco, if not a little bit better, versus Orkambi and Symdeko, which were maybe about a 4% improvement in FEV1. This is more like 14%, and Kalydeco is about 12%. So as good as or better. Now, of course, that takes into account where someone is with their lung function. As we're learning, and of course, if we're starting these medications in younger children, we may not see as dramatic of an effect. It's really about the long-term effects, right?
I'm just wondering what 12% kind of looks like, you know what I mean?
Yeah, and I actually have a little bit of information on that. That's a great question, yeah, because it's different in the real world, right? And we know that not everybody who's eligible is taking that either, and it's such a personal decision. And, you know, everybody's counseled about it in different ways, and we know that the CF community is very well networked, and so I've had a lot of conversations with people in clinic about, well, you know, I'm listening to the scientific data, but I'm also listening to what people's experiences are, and, you know, I feel like I want to give it more time, or I feel like I want to jump on this right now, and then I want to reassess. You know, so everybody kind of has a different approach, right? We'd like for any of these therapies to be a no-brainer, right? Like, this is what we're doing next. We're hopeful that this may be one of those. Kalydeco, to me, felt that way. But admittedly, we don't have very many people, 6% of people are eligible for that drug. We don't have very many people in our center who are eligible. So we've had some who said, I'm not sure. So it's, you know, the personal decision, for sure.
What exactly does it collect?
So it basically is more effective at getting the protein full properly so that it can get most efficiently to the cell surface, and then opening the channel, basically, so that chloride can pump through it and normalize what goes on at the cell surface. So it's kind of an extra, the delta 508 is very tough to fix, and so it's kind of like another layer of fixing the basic problem. What they've learned through research is that it takes kind of multiple approaches to get it to be effective.
Remind me of Kalydeco, like, so
It's the type of mutation. Basically it's a mutation where the protein is made and gets to the cell surface, but it just doesn't open. But it's only 6% of people actually have mutations that result in that problem. Okay, so it's kind of what you know, genetics over time, where kind of people have landed. And they started there because that was one of the easier ones to fix, right? Now, I should note that they also talked about, and this is important, and there's lots of other stuff on other therapies, but that about 7% of people will not ever probably be eligible for a modulator because about 2% of people have very tricky mutations that are just too challenging to figure out how to fix. And about 5% of people just don't make CFTR at all. And so you can't go from nothing to a functional channel that works the way that it's supposed to. So the focus for people with those mutations is just a totally different approach, right? But there's a lot of work going on in that area. And so when you hear about some of these really crazy technical things that are being worked on with replacing segments of you know, RNA and all kinds of things, that's who we're talking about, is people who would not be able to have a modulator therapy. Okay, so the science behind that is extremely difficult to work out, but it's a big important focus.
just for those who are on the phone, or if you're on WebEx and you want to ask a question, you can either just ask on the phone, or if you type in a chat question, we'll see it and we'll get it asked.
Right, and we can come back to any of this stuff too. Let's talk a little bit more about ORCAMBI. We talked about these phase 4 studies where we look at real world experience. So what we know from people who have participated in phase 4 studies, and most of the data are 12 and older patients because they've been taking it for longer, but this information is being collected on younger children now as well. We know that when we compare the annual decline or decrease in FEV1 or lung function, it's actually less rapid in adults who are being treated than without. So a decrease in lung function of about 1.3% per year versus 2.4% in people who are not taking ORCAMBI. People have fewer pulmonary exacerbations, even those who don't have an improvement in their lung function. Initially, body mass index, or kind of weight and how proportionate your weight and height are, improves, but then appears to plateau. In the real world, the discontinuation rates of people who choose to stop taking the medication or have to stop taking the medication for medical reasons is actually 17% as opposed to 4% in clinical trials, which is a little bit disappointing, but something that was anticipated, and one of the reasons that looking at SYMDECO was such a priority, and of course looking at triple therapy is such a priority. It's actually higher in people with severe lung disease who were not participants because of their low lung function in clinical trials. Just the impact of making CFTR work, it causes a lot of respiratory symptoms in people with severe lung disease. As I mentioned earlier, there's less apparent impact on outcomes in children, but probably because many children are healthier at baseline. And then a big thing that has been a concern is about psychiatric symptoms. And new presentations of mental health conditions or worsening of anxiety, depression, other mental health conditions appears to be more of an issue in our adolescent and young adult female population. We're learning a lot about this right now, but it has led to some people having to stop taking obviously something that has to be, there was a lot of discussion about this at the conference. There is CFTR in the brain, and it may be in parts of the brain that help regulate mood. So it's pretty interesting how they're looking into this, giving a lot of alerts about other outcomes we need to be looking at in clinical trials. I'm going to go on to the next.
I actually have a question from
Sure. Oh.
Any info on whether or not triple combo has a negative impact on liver, like discussed?
Yeah, that's a great question. So one component of those is SYMDECO or ivacaftor, tezacaftor, which a small percentage of people have significant liver elevation in liver tests and have to stop the drug. Some are able to restart it. Some people have trouble only at certain times, like if they're sick or taking antibiotics. Again, this is something we're learning a lot about. The additional corrector that is a part of that didn't look like it caused more liver problems in those phase 2 studies. It looked like about the same percentage of people that had abnormalities in liver function tests. There were, I wish I don't have all my notes, but there were in those studies, I think, no discontinuations in one of the drugs and 1 or 2 out of the participants in the others. So it was very infrequent and none for liver function tests. Okay, so a few more things on modulators. SYMDECO or ivacaftor, tezacaftor, also for people with 2 copies of delta F508, in clinical trials had the same effects on lung function and pulmonary exacerbations, but people had less chest tightness or a drop in lung function at start of therapy. So early on, people with more moderate or severe lung disease would have a drop followed by improvement, but that drop was likely because of all of the changes that are going on with the characteristics of mucus and mucus clearance. It had really less or really no kind of a neutral impact on body mass index, but it had a lower incidence of serious adverse events. And this drug was approved last kind of winter into spring, and so we're going to be learning a lot more about this in the longer term, but also, of course, it's a component of triple therapy. I would say my experience has been for people who've switched from Orkambi to SYMDECO or who've started SYMDECO has been generally quite positive. People have not felt particularly different, like it wasn't a change for the worse. But people who have trouble tolerating Orkambi have done a little bit better so far. But we're only talking about like 6 to 8 months of experience. But this is the word on the street. So, and then Kalydeco or ivacaftor. So you had asked the question, Michelle, about in the real world. So it looks like after initiation that there appears to be a sustained improvement in FEV1 versus people who are eligible but not taking it, who have that kind of 2.5% decrease that we see on average in the CF population over 2 years. So it looks like that is sustained. Fewer pulmonary exacerbations and admissions to the hospital, actually a lower mortality and lower rate of lung transplantation in people who are taking Kalydeco. And that's what we're going for, right? So this is exciting to see. Also lower rates of other CF complications like diabetes, CF-associated liver disease, bone and joint disease, and actually depression. And so this is one of the things that's also making people wonder, like, what is it about the effects of these medications that might be different? Is it the mutations? Is it that it's more effective? What will we see from triple therapy? Also decrease in burden of certain infections like Pseudomonas or Aspergillus, which is a mold in the first 2 years of therapy, and also improved fertility in women. And some of that might be because of the, I didn't put that BMI or weight outcomes here, but that also appeared to be a sustained improvement from baseline, and improved fertility may be in part due to that, and also probably in part due to improved CFTR function, which can interfere with ovulation and cervical mucus and things that are important to conception for women. They also recently released that Kalydeco can be continued during pregnancy, not during breastfeeding, but during pregnancy, and we don't have that capacity with the other modulators that are available. So tough decisions around that for women for sure. Okay. So before we go on to the next set of therapies that they talked about, any other questions about modulators? That's a great question. It's funny that you mentioned that, because something made me think of it, a question from somebody about who just started or can be. So the others are currently available ones are, but I'm assuming that triple therapy also will be. But yeah. So how you take it and when you take it are going to be important.
They're working on a single dose with some other.
Yep, exactly. So a different release. Making it easier to take, because one of the reasons that we might not be seeing as much effect in the real world is that it's still medication that you have to take, and so it becomes a part of the daily routine, and that can just be very overwhelming, as you all know. And so people don't choose to take it 100% of the time, and so it's not going to be as effective. Versus if you're being watched in a clinical trial where you know that you are, looking at the effectiveness of the drug, you're probably more invested in doing things exactly as prescribed. At least for that portion of it.
I've got a question from online.
Yeah.
From Jacqueline. What are the chances the triple drug therapy may be eventually be available to younger children? She's a 4-month-old with 2 copies of Emily. So that may be it.
Absolutely. Sounds great. Yeah. So, well, I would hope that around the time that 4-month-old is in the 2 to 5-year-old age range, that would be because of the sort of sequence of testing in 12 and older, and then 6 to 11, and then 2 to 5. So we, to be determined, but if we think about the time frame for a clinical trial, we're talking about the next, in the next 2 years, studying that younger age group. I wanted to shift a little bit to thinking about kind of another facet of therapies. And there was actually an entire, well, 2 really, plenary sessions. So the big sessions where everybody who's at the conference attends, they live stream it, you can watch it, it's video captured. And I don't know if any of you have had the chance to check these out. Those sessions are great because there's a lot of information, but sometimes it can be a little bit deeply scientific, depending on the topic. And if you like that, you're in good shape. And if you don't like that, sometimes you need a little bit of help kind of teasing out the important pieces of it. But those are available online, and they were actually, I thought, really well done. So if you can go to the next slide, I'm going to talk about infection and inflammation and kind of therapies that are targeting these. So when we think about what causes airway and lung tissue damage in CF, we spend a lot of time thinking about CFTR dysfunction, so correcting the basic defect, right? Because that contributes by making the airway, the surface of the airway abnormal, it contributes to airway inflammation, which is ultimately what causes damage. But infection also contributes to that, and impaired mucus clearance related to the CFTR dysfunction also contributes to that. And once there's damage to the airways and lungs, it kind of feeds back on impaired mucus clearance, infection, inflammation. So it's kind of a cycle of damage. And so in order to help do the most to reduce the likelihood of damage, it's not all just about correcting CFTR dysfunction. Now, you guys are all familiar with treating infection and helping facilitate mucus clearance, because that's a part of your kids' therapies. A lot of work is being done in infection and airway inflammation. So I wanted to highlight a few things from the conference. You can go to the next slide. One of the big messages in the plenary session on infections are that respiratory infections are the greatest because the inflammation will still be a major cause of lung damage. The CF Foundation is investing millions and millions of dollars into an infection research initiative. The goals of that are to improve the detection, quickly figuring out what the infectious organisms are, diagnosis, treatment, and outcomes. Some trends, and there's some pictures that show here people with CF who cultured positive in 2017. So this is a sputum culture or a throat swab. Almost half cultured Pseudomonas, about a quarter cultured resistant staph, and non-tuberculous mycobacteria, which if any of you have had to deal with, this is a really challenging organism to treat. Very resistant, very slow-growing bacteria that require multiple drugs to treat, and about 13% of people have had a positive culture for that in the last year. And some of our other more resistant organisms are less prevalent. But overall, Pseudomonas appears to be decreasing. Some of that may be because of our chronic therapies. Yeah.
Was this from the conference? Was this like off the registry?
So this is, the pictures that I have are from the registry reported summary. Yep, exactly.
Sorry if you said that.
Yeah, no, it's okay. I think you came in after I pointed out. So I have a lot of these that I didn't give credit to. They're all from the same thing. And this is available online. It's just kind of data to
I just wonder if it's UNC.
No, sorry. It's nationwide. Sensitive Staph aureus is actually increasing. Resistant Staph aureus, or MRSA, has kind of plateaued. And then we talked about the non-tuberculous mycobacteria. So if these are terms that you're used to hearing from the results of cultures, this is kind of where things are. The registry report has figures that show kind of trends over time in these bacteria. And really, that means a few things, like if your child is sick, what antibiotics do we use? What recommendations do we make for treatment? It also, there are some implications on injuries to the airways and lungs with some of these bacteria. So we want to know what's in cultures we want to treat effectively. And it's helpful to know what's going on kind of nationally, but also regionally with some of these bacteria. It helps inform the way that we look for bacteria in cultures and kind of what our treatment patterns are. Do you want to go to the next slide? They reported on some interesting stuff that's going on. There are a couple of trials that their acronyms are STOP and STOP2 that look at treatment of pulmonary exacerbations. So lots of different things that they're looking at in a large cohort of people from around the country. When is it better to use oral antibiotics versus IV antibiotics? How long do we treat? Where do we give IV antibiotics, in the hospital or at home, or a combination of those things? And then using the early response. So when we first start treating somebody, are they an early robust responder? Do they have a rapid improvement in symptoms and lung function if they're old enough to measure their lung function, or do they not? And does that help us determine the treatment plan, right? So we worry about loss of lung function with each exacerbation, and what we have learned over time is that when we don't have aggressive treatment and good follow-up, we tend to see a steeper slope of decline. So people who respond robustly and early probably are okay with shorter courses of antibiotics. People who are not responding quickly probably need longer courses of antibiotics or more incorporation of IV antibiotics. And that's just not an individual person, that's with each exacerbation. So kind of what are our measures? Somebody found that. I don't like the idea of a long course of antibiotics. Yeah. So lots of stuff that will be coming out from this that hopefully will help inform us about kind of the best approach. And when you guys are sitting there saying like, does this really have to be our plan? Like this is kind of a huge burden. We can say, well, this is kind of the evidence to support it. So let's think about how we make this doable, right? So this, I think, will be very informative. There are groups looking at the effects of the CFTR modulators on microbiology. What bacteria are in the lungs when people are on modulators, and do we see changes? Looking at the impact of azithromycin as a chronic therapy and inhaled antibiotics on chronic Pseudomonas infection, and many of you are familiar with those therapies. There's a lot of work being done in that non-tuberculous mycobacteria, that really challenging infection, and Denver is the kind of lead site for a nationwide study looking at how do we actually diagnose this as infection and not just organisms living in the airway, not causing problems, what warrants treatment, And then there's patients. These are, again, acronyms for some complicated thing that doesn't really turn out to be that way, but they call it that anyway. What is the right treatment algorithm? So how do we decide, which regimen of antibiotics and for how long, and who qualifies sort of for what level of treatment? So we expect a lot of information over the next several years from those studies. And then there were some really cool things about anti-infective studies that are not antibiotics or antifungals or other things that you think about as kind of like the standard treatments, but treatments like gallium, which is just a molecule that actually fools bacteria into thinking that it's binding iron. Iron is really essential to a lot of processes in bacterial replication and metabolism, and gallium is like the same size, and so if gallium is around, those bacteria will bind gallium instead of iron, and it is something that comes with little side effect or burden, but can really dramatically alter the way that bacteria survive in the airway. This is being studied primarily out of Seattle in adults, lots of cool stuff to come. And inhaled nitric oxide, which is a therapy that is used usually in the intensive care unit, but is an inhaled therapy that can have some anti-infective effects as well. That's being kind of in early studies. MUSC is a site for that, and they're looking at that, the effects of inhaled nitric oxide on different types of bacteria and organisms. Yeah. Okay, so lots more to come. Study. So the kind of turning a little bit away from infection, but more to inflammation. This is a really complicated aspect of CF that I think, there's a lot that we know, and there's even more that we don't know. We know that inflammation in the airway is unique to CF. It's not like any other type of inflammation. We know that CFTR modulators can help reduce some aspects of inflammation, but that can't be the only target, right? Because there are other things that cause inflammation, like infection, for example, or that kind of cycle back after damage has been done. It's important to know that targeting inflammation is tricky because the inflammatory response is really needed to help fight infection. So if we take away the inflammatory response by suppressing it, then people get worse infections. They get sicker with infection. So there has to be a balance. And as you hear about these therapies, and I have some that are all these crazy names, and they're all like nothing except for high-dose ibuprofen, which is that we are, as a center, not huge fans of this. Some of your kids may be on it, may have used it. It is an effective anti-inflammatory agent in CF, but it comes with a lot of side effects, a lot of gastrointestinal side effects, kidney toxicity. Some people tolerate it very well, some people don't tolerate it at all. Some centers really use it heavily, and we're just, at UNC, we're not one, and I don't know about Duke, but we just as a group don't use much of that. That's been an available therapy for years, studied many, many years ago. These other agents are really what they're looking at as opposed to as opposed to lung function outcomes is really the number of pulmonary exacerbations, because our hope is that the inflammatory process will be interrupted and people won't have such a robust response to infection and get as sick. So if you are approached about participating in any of these studies, they may look a little bit different if you participated in other clinical trials in terms of the measures that we're looking at. And these, I think, are further down the road, very likely, because they're kind of newer compounds that are being looked at closely, but I think there's just more work to do with kind of the message. Mucus clearance is the other big kind of thing on our diagram of what's important in terms of managing lung disease, and many of you are familiar with Dornase or Pulmozyme and also hypertonic saline. So those are available. It feels like forever have been studies of mannitol, which helps draw water into the airway lumen, that is being studied as a dry powder inhaler that it sounds like could be beneficial, but it's been talked about for a very long time, and I'm not really sure of what the logistical reasons are that we haven't seen that emerge on the market yet, but it looks like it's getting there. And then again, a bunch of other compounds, lots of things that are in phase 2 trials. Lots of different approaches to this problem of impaired mucus clearance. And I put this one up here, Spirex, which some of you might be familiar with because it's a regional company, but that particular compound helps improve airway hydration by basically addressing a problem that contributes to dehydration of the airway surface, which is excessive absorption of sodium into the cell, which is just a side effect of having abnormal CFTR. So stay tuned. There may be more. We may be talking about ways to improve mucus clearance that are a dry powder inhaler or even pills, eventually, as opposed to nebulized treatment.
What phase is that?
The Spirex is phase 2. I can't really see that, but it's the third up from STX. Yeah, exactly. Why don't we go ahead? Again, these are all things that are sort of coming along, so stay tuned, but not lots of detailed information about these. At least not at the sessions that I can understand. Some of the basic science sessions go into a lot more detail on these, and they're really interesting, but it's kind of, it's a little out there for those of us who are trying to think about how we apply this to our patients right now. Thinking about therapies and lung disease, lung transplantation, also highlighted here. In the last year, there were 250 lung transplants reported to the registry. There are people with CF who have liver transplants because of liver toxicity and CF-associated liver disease, and then 8 kidney transplants that very likely were in lung transplant recipients, people who had lung transplants and had kidney problems related to the side effects of medications that are needed to help prevent the body from rejecting new lungs. The overall number of CF transplants reported to the registry continues to increase. This is not because people are getting sicker. This is because transplants are more available, and actually people who are older are eligible for lung transplant. The transplant community has changed drastically. There are now people with diseases like COPD, interstitial lung diseases that are offered transplants in their 70s if they're otherwise healthy. So we're seeing a shift in the age overall. If you can go to the next slide, there are a few initiatives that I think are important. This is a touchy topic. This is something that a lot of people worry a lot about. I think what's important to know is that there's work being done so that those who may qualify for a lung transplant will have the best possible chance of a good outcome. So one of the really exciting things that was reported was that survival after lung transplant is better for adults with CF than other lung diseases. So our kind of line when we're talking to people about outcomes of lung transplant is that the average survival is about 5 years. It's actually closer to 8 years for adults with CF. So this is great news. And that's just the median. There are 25-year survivors of lung transplant as well. And it would be longer than that, except that that's about when the first lung transplant was done, maybe close to 30. CF Foundation initiatives around lung transplant have really blossomed in the past few years, partially because of coming into a lot of money from drug development, also because of sort of changes in leadership and wanting to make sure that we're focusing on our population of people who have advanced disease in a little more specific way. So looking at how someone is referred for a lung transplant, making sure that people have equal access. If they don't live near a transplant center, how do we facilitate getting them access? And looking at how to improve outcomes that are things that are very specific to CF as opposed to the majority of lung transplants that are done for other conditions. There's also an advanced lung disease initiative, and I'm a part of that. I'm a representative from here. There are about 30 of us from across the country. And this is really focused on the clinical care of people with advanced lung disease. So how do we make sure that we're optimizing our clinical care? Okay. So there will be some guidelines and recommendations that will mostly affect like the way that we practice, but those are all available for people to look at when they're published if you're interested. A few words on other really important aspects of CF. I made it to a lot more lung disease sessions than I did nutrition and sessions and endocrine sessions, but I wanted to summarize a few of the key highlights. The figure on the left again is from the registry report. The median body mass index percentile, so this is that 50th percentile that we're shooting for with body mass index, because that degree of BMI is associated with better lung function, better lung health outcomes. In 2007, the median percentile was 49. It's now 57. Again, lots of reasons for that. And the percentage of adults meeting the BMI goals, and those are actual numbers. So like if we calculate our own BMI, a normal body mass index for an adult who doesn't have CF is 20 to 25. For someone with CF, the goal is 22 for women and 23 for men, again, tied to lung function outcomes. And 41% of people were meeting that goal 10 years ago and 52% last year. So again, seeing improvement in these areas. Something that got some focus and has gotten some attention in sort of the clinician world because of publications about GI disease is the CF Foundation's Digest program that helps train GI doctors and nurse practitioners to manage CF-associated GI problems very specifically because it's different than a lot of other conditions. There have been some developments in pancreatic enzyme replacement. If any of your kids have feeding tubes, there's this nifty cartridge enzyme that now can be given in line with overnight feedings and can really help with absorption. We've had some people have a really nice improvement in their GI symptoms with that. And then there's a lot of research going on in CF-associated liver disease, which is not clinically significant, doesn't cause a lot of problems for the vast majority of people. We mentioned that some people have severe enough liver disease to need a liver transplant. That's a very tiny fraction of people. But we do know that people have problems with abnormal liver function tests, and especially as new drugs are developed that are going to be metabolized by the liver, because that's what the liver does, we want to understand the mechanisms that drive liver disease so that we can try to come up with therapies that help protect the liver. Okay, so that's been an important focus as well. Can I go on to the next slide?
Got two questions.
Oh, you got some questions?
Online. One from Jacqueline Morgan that I think we'll save to the end because it's a very general question. But Gwen Lee is asking a question, I think, back on your corrector slides. Is it possible the triple combination may help patients with cirrhosis of the liver? My son's numbers were up and down prior to starting Orkambi, but since he has been on it, his levels have been more stable. We compare his blood work before and after starting it.
Yeah, that's a great question. And we've seen with Kalydeco or ivacaftor for people who, the small percentage of people who are eligible for that drug, a decrease in CF-associated liver disease, right? So the same drugs that are metabolized by the liver that can cause injury to the liver actually are also hopefully helping the basic problem that's causing the liver disease in the first place. So it's a balance, and it's probably very individualized, but our hope would be that, yes, triple therapy will ultimately have positive impacts on that, on development of diabetes, a lot of the other complications of cystic fibrosis. So endocrine and reproductive health also highlighted. This is looking at cystic fibrosis-related diabetes for those of you who have 10-plus-year-olds. You know that our annual sort of protocol is to screen for this because we see increased presentation of this condition as people get older. About 12% of children and 35% of adults are somewhere on the spectrum of cystic fibrosis-related diabetes. Screening, the goal is universal screening of people 10 and older, but we are not hitting that mark. About 43% were screened in 2017. As you know, if you've been through that, it's a long test. If you haven't been through that because your kids are too young, but you've had a pregnancy and you know what that glucose tolerance test is like, it's the same thing. It's a lengthy clinic visit where everybody tries to tackle you while you're sitting there. The child is unhappy because they just say it's this big bolus of sugar after not eating for hours and hours. But it's a little bit of a cumbersome thing. So our goal is to get everybody screened. So kind of expect that that's a piece of thing. There's a lot of work going on in enhancing therapies for CF-related diabetes. You can go ahead. Also in this kind of zone of endocrine and reproductive health, you know, we talked about our growing adult population. We know that the number of pregnancies among women with CF has increased steadily since the 1990s as opposed to the U.S. population where it's actually declining. So that's, again, for reasons of improved outcomes and the possibility of pregnancy for a lot of women who would not have been able to consider it back earlier. There are a lot of new resources that have been developed over the past couple of years for female and male sexual and reproductive health. The CFF.org website has some really nice sections on reproductive health, both kind of information on things like fertility, impact of pregnancy on health, and parenting with CF, and also blog posts about just people's experiences. And some of you have written some of these blog posts I know in the past, and I think a lot of people find those really helpful. Boston Children's Hospital put together an entire page on women's health that's specific to cystic fibrosis. Tracy Kazmersky, who is a researcher who's now at Pittsburgh but was in Boston for a while, has worked really hard to ensure good information is available, particularly to young women with CF. But these are good resources if you have adolescents or emerging adolescents or adults, just to find. And for you guys, as you are preparing to have conversations with your kids about, hopefully with help from your CF team, about reproductive health. Yes, ma'am.
So, I'm asking for everybody.
for the team is really brave. We know this.
So, I've talked to our primary physician about sperm testing, and so do you know, is that something that's covered by insurance?
It is, I believe, by most insurances for men who have a strong reason to suspect infertility, right? So we actually have.
I'm more worried about fertility.
Well, that's which is possible. So there's actually a urologist at UNC. I don't know what Duke's resources are, but Matt Coward, his group really specializes in male fertility.
And I think he mentioned that. I just wasn't sure if you knew.
They do a lot of testing, so they do consultation, and I think as long as they recommend it for specific reasons, it's typically covered, is my understanding. So that's a really good question. He just came and talked to us maybe 6 months ago, and that question came up, and I'm pretty sure that it was as long as there's documentation of the rationale for testing, sometimes at an earlier age that and men might choose to test otherwise.
I don't think we're ready. Like, I don't think my son's there. I'm just saying when it's time.
Yeah, when he is there.
Yeah. Yeah, you over there need to be more concerned.
Asking for him.
Yeah, I'm asking for your first son.
More worried about myself.
But these are important issues, and it's also, we have talked a lot as a CF team about what a crappy job we do of addressing these issues, and how really, we need to be doing it, and we need to be able to partner with parents. And, we've learned a lot from these studies about, people want to know at the age that they're learning about puberty, and, a little bit later than that, but thinking about things like eventually having kids. That's a time that we don't want them to necessarily find this information by reading about it online. We probably want to have a conversation so that it may still be shocking for boys to find out that they're very likely going to be infertile, and for girls to find out that they may have more difficulty conceiving, or it may be there may be some health hazards to carrying a pregnancy depending on their health status. But really, we need to have those conversations.
Well, and with Google and the internet, I'll tell you, my son busted out with vas deferens before I even mentioned it, and I was like, they're looking.
They're looking.
Are the modulators able to reverse that?
So with women, it looks like there's improved fertility. With men, the problem is actually that the vas deferens typically is not present. So some men produce sperm, but it can't get out. So for men who do produce sperm, it can be extracted, and they can have their own children. It's a complicated thing, right? It's a lot to think about. A sensitive topic, and it's a hard topic for you all to think about with your kids who aren't yet of the age where they're thinking about these things necessarily. But it's important to anticipate that, because they will find out, and we hope that they come to all of us with questions, but we don't know that they will, right? So anyway, good resources, lots of good stuff to read about, and talk to us about it. All right, so living with CF. So this is a broad topic, but I wanted to highlight a few things again that were really, I think, important. Mental health being a huge one. Many of you have been involved with efforts to enhance mental health screening in our clinic. The recommendation from the international guidelines for CF that were published in 2016 were that everybody 12 and older be screened for anxiety and depression. Actually, the American Academy of Pediatrics now recommends screening for depression universally in kids, I think, 13 and up. So this is something that the depression part would be happening in your pediatrician's office, but we're trying to bring anxiety as another major mental health issue, right, into our screening process. So Lynn has been extremely involved in this. You worked quite a bit with this effort as well, kind of given, so you're going to be running into this if you haven't already. The goal is, again, to screen 100%. It's steadily increasing. We've been fortunate to have funding for focused mental health coordinator to work on developing screening protocols, and then what do you do with that information, right? So a few things that we can talk about our own center, but I wanted to highlight a few things that are being done kind of nationally as well. So first of all, the reason, right, why we're doing this is that depressive symptoms are 2 to 3 times higher in people with CF than in the general population. This is true of many chronic conditions, but we know from studies that there are some major negative health effects of this, right? In addition to just depression really being a bad thing to have to deal with, it can lead to problems adhering with treatment regimen. People with depression have more pulmonary exacerbations, lower lung function, lower body mass index, so nutritional issues, higher healthcare costs, impaired quality of life, and actually a couple of studies have noted earlier mortality, so people don't live as long if they have significant depression. So this is really critical to be addressing. Anxiety is also much more common in people with CF, and anxiety and depression are more common in parents and caregivers of people with CF as well. So how we address that globally is a little bit trickier, right? Because we're not equipped to provide mental health services to parents and caregivers, but we are there to listen to concerns and help identify resources. I think that's a really key message that hopefully many of you have gotten from education that Lynn and others have provided. Right now, there's a big study out of Mass General in Boston looking at CF-specific cognitive behavioral therapy. So if any of you are familiar with CBT, cognitive behavioral therapy, it's for anxiety and depression, and it's really focused on kind of identifying, understanding, and then kind of aberrant thinking about things that drive anxiety and depression, and basically trying to change those thinking and behavior patterns that drive those problems. It's been demonstrated to be very helpful in anxiety and depression, but there are some very, things that are very specific to CF that this group is trying to focus on and trying to make this maximally effective. There are studies going on in telehealth. There's one called Project Uplift that there's information about on the CF Foundation website. Motivational interviewing is something that we have worked a lot. Some of you met Nadia Islam, who was a postdoctoral fellow in psychology who worked with us over the past year. And she had a real particular interest in this and has worked a lot kind of our mental health team. Some of you may have participated in some motivational interviewing training, but the goal of that is to really help to use conversation to kind of help empower people to overcome basically ambivalence or negative feelings about things that get in the way of their ability to do things. So for a lot of kids with CF, especially as we reach adolescence, what's keeping me from doing my treatments to stay healthy? And there are many, many, many things, but how can we empower people to work on the things that are the biggest barriers to them, and value the role of therapies in keeping them healthy.
And Nadia worked not only with, did some research with some parents, but also did training with all the practitioners too, to kind of talk about different communication strategies to be able to better engage with the patient, and have better communication strategies to elicit kind of that change talk. And so we're working on ourselves.
We're working on ourselves. But it takes a lot of repetition of that information and changing the way that you practice to be able to do it effectively. So if you're not seeing changes, it's not because we don't mean well. It's because it's hard to teach old dogs new tricks, I guess. But in any case, these are things that you might find helpful in parenting also, right? Yeah. We all know those challenges of trying to get our kids to do things that they should know are good for them, but they just don't because they're kids, right? Yep. Yeah. Yeah, there's some good stuff in there. So if it's something that you're interested in, it's something that we want to continue to offer, there's some information to parents about, and we're going to keep working.
We are going to keep
working. So, for sure. And then another strategy is acceptance and commitment therapy, which Lynn can really speak to. This is something that we're going to be implementing hopefully in the next year.
Yeah, and it's just another kind of therapy approach, kind of based in mindfulness. It's a little bit, an offshoot of cognitive behavioral therapy, but instead of trying to change those distorted, obviously we want to address distorted thinking and non-helpful thinking, but this is more not trying to push away and kind of accepting emotions and So I'm at the beginning parts of training Maribeth for our psychologist, mental health coordinator who is doing a lot of training and with Amy and I, and is available in clinics. So hopefully we'll be able to offer more services and resources for all of our patients and parents.
Great, and it's neat because, of course, we can implement these things like practically in our work, you know, to the extent that we can, right? You come to clinic and you're there for so long and there's so much to accomplish, but when this is a major concern for kids, we want to have really good access to effective therapies. And we are being guided by active research. There's a real investment in this as being a key component, sort of the line that has been used, and I totally agree with, is that there is no health without mental health, right? We're not going to be able to take care of ourselves if we emotionally are not able to do it. So that's something that we really want to be emphasizing. So this is another thing that if you have questions about it, make sure you ask them. All right, so a few more topics, transition to adult care being one that some of you are facing fairly imminently. It's a hard topic for all of us to talk about. When I did adult CFTR, I got to just take my beloved pediatric patients with me to the adult clinic, which was so nice. But lots of ongoing quality improvement projects nationwide. We have a lot of things that we've been working on at UNC, Center Sharing Information and Resources, CF RISE, which stands for Responsibility, Independence, Self-Care, and Education, is a transition kind of support and education resource that some of your kids might have been participating in, and we are bringing down the sort of age criteria for utilizing CF RISE and also just overall focus on transition to get kids hopefully more actively engaged in understanding CF and in taking care of their CF. These next two things here that are with links to web pages are some CF Foundation resources. I don't know if any of you have heard about BreatheCon. This was a virtual event that was basically put together by adults with CF for adults with CF, and it was ragingly successful. People absolutely loved it, and so they've developed mini cons which are topic specific. It's for people 18 and older with CF, and some also are for family members, and FamilyCon is also of course for family members. And so these are all virtual events, and they have really a wide array of cool things that they do. They usually are like day and a half long. You can come in and out. There are, group sessions. There are, keynote speakers, lots of opportunities to connect. So there's a link for that. And then CF Peer Connect, for those of you with older teens, is a one-on-one mentoring program for adults with CF, and also for family members. So there are peer mentors that are parents and caregivers as well. And that can also be topic specific. So it may be that, I want a mentor who can help me think through like what the transition to college is going to be like. Or for some of our patients, I'm thinking about a lung transplant. I'd like to connect with somebody who's been through that decision-making process and kind of through, just to have someone who, because I'm fairly isolated with having this disease that's rare, and that I'm encouraged not to be in the same room with someone else who has it unless they're my sibling. This is a way to connect with somebody meaningfully around CF issues. So those are some things to check out. If you want to go ahead to the next. Palliative care is another issue. This is near and dear to my heart because this is part of what I practice, but I wanted to give you the definition. We have a working group that has looked at kind of what palliative care means in CF. Our definition that we've come up with using other definitions that are available is that it focuses on reducing physical and emotional symptoms and improving quality of life for people with CF throughout their lives. Palliative care occurs alongside usual treatments and is individualized according to the unique goals, hopes, and values of each person. Palliative care is a specialty in medicine. It's also a part of what you do as a clinician to providing symptom relief to your patients, helping them think through difficult decisions. This figure here is from a paper that looked at palliative care for people with lung diseases and talks about how the dotted line, palliative care rides alongside what we would call in CF, because there isn't a cure, restorative or disease-directed care throughout someone's life. And at periods where the disease is more intensified, palliative care is more intensified. I put this figure up here because the awkward word in here, if palliative care isn't already awkward for you, is hospice, which is under the umbrella of palliative care. It's appropriate for people who are nearing end of life. but is not at all the focus of palliative care. And so if you guys hear about palliative care in the context of CF, we know that there are many people with CF who are facing end-of-life decisions. Many people are many years away from that, and we hope will live full life expectancies, but we're still dealing with a disease that has a tremendous burden and has a lot of uncertainty and unpredictability. If you can go to the next next slide, what we're working on through the CF Foundation, and I have a position with them actually focusing on developing clinical care guidelines for palliative care that will include how do we incorporate palliative care principles into our practices, coming up with toolkits, practical tools to support decision-making, to facilitate communication, to help with decisions about really serious things, and also some decisions about day-to-day things that we think of as pretty routine, but you may think of as very serious or life-changing, like feeding tubes or IV antibiotics or things that are really have a big impact on you. And we've addressed a lot of different issues, and what we're looking at is what does the CF care team do? What do specialists in palliative care do? How do we incorporate specialists when we're not, as a team, meeting the needs of our patients and families? Do you want to go to the next slide? This piece of living with CF kind of then funnels into this kind of notion of partnership with your CF care team. So the third plenary session, the big session, was on something that is called co-production. This is the session, if you're going to watch anything, I think, from the CF Foundation, if you have an hour to invest in something, I think is very, very meaningful. It was given by a physician who actually was one of my fellow residents who doesn't do anything with CF care. She's an internal medicine, hospital-based physician who's really interested in how do we interact in healthcare, right? So there's sort of a notion about what do we need as patients and families, what does the CF care team or any healthcare team bring, and how do we work together to create a product, right, that is acceptable, beneficial to each individual person living with the disease. So this last session of those three plenaries was very much focused on kind of like, how do we do this? How do we actually communicate? How do we improve the value of care around CF? So the main speaker talks about a lot of really interesting things. There were some beautiful videos of people with CF who shared some of their stories, and they had some panelists who I think just really brought a lovely message about kind of what their experiences have been. So I would really encourage you to check that out. But the key things, and there's a lot of stuff on the Foundation website about this co-production or partnerships. They talk about ways to partner with your CF care team and give examples of be open and ask for help with your care plan. Share what's going on in your life. Communicate outside of clinic, so it's not just clinic where we're having important communication about needs. We are here for you when you need us. Invite other people into your care planning. So if you're a person living with CF who's old enough to be functioning independently, it doesn't mean that your family members or your closest support shouldn't be there to be a part of it. Or if you're a parent, maybe a grandparent is a really key person to have with you as a part of your CF care team, your personal care team. And approach difficult conversations with respect. And then the way that the CF care team can partner with you and your family is really parallel to this, so creating a space for open and honest discussions. We don't want people to feel that topics are unwelcome or to feel intimidated bringing things up. Sometimes our role becomes being very much cheerleaders, and we want to get back to baseline, and we want to, always be striving for our best. And sometimes what you need is a little more of, this is really hard, and I need your help figuring out how to do this. And that's not actually my focus right now. So we can't block communication about that. We have to understand that it's more than CF that we're dealing with, right? We're dealing with people living their lives. We have to invite sharing between visits. Please don't wait to call us if there's something you're worried about. Creating a space where everyone's voice is welcome, because the family, the community around the child or person living with CF is different for everyone, and approach difficult conversations with respect and an open mind. So these are all concepts that we think seem kind of like no-brainers, but they don't always work. It doesn't always happen. So we want you guys to know that this is something that we are all also working on becoming kind of our best selves in our practice, and it's in evolution, but we want you guys to think about giving us the feedback about how to do a better job with these things. recognizing that it's going to change as your child gets older and more independent, and the struggles change for sure. A few more things on just partnership. Community voice is something that is available to you guys if you're interested. Also, the CF Foundation is open to adults and family caregivers of children and adults. It currently has over 800 members. There are lots of things that go out on that listserv, I'm told. I can't be on it, but I'm told it's very helpful. It's also used a lot for things like surveys and trying to get feedback from people about all of this stuff. But your participation and kind of opportunities are guided by your schedule and your interests. So you create a profile so that you don't get every single thing that comes across, but you get things that you're most interested in, or you can indicate that you would be, specifically wanting information about certain things, or that if you are interested in participating in a greater way, there are ways to offer yourselves for that too.
Are adults, is that considered 21 and over?
18.
Oh, 18.
Yeah, I mean, all of a sudden, 18 can do everything almost. All right, and then the next slide, I think that's it. So, questions, thoughts? Yes.
No, go.
No questions from you.
So, no, this is legitimate. This is not relevant in my personal life anymore, but when we were first diagnosed, we felt very, like, the assumption was that we were not going to have any more children. Okay? And so the reason in my earlier career, I was able to go to several CF conferences. And so I just was wondering, has there been an increase in the discussion on how to address that, or having that discussion? And I'm also asking because in my professional career, I work with diagnoses where we deal with autism, I work in genetics. And so, and we have one specific patient population where we have an annual family meeting, and I have brought this up, and I would like this to be a central, like, whether it's a breakout session or a discussion topic, and because no one talks about it, and it was just something that, I mean, for those who know, my son is 16, it was just something that was never addressed. It was an assumption, and I know earlier years in my friend group here, we talked about it, and so I just was wondering, has it evolved any since?
But I would like to say that it has. A part of the goal of newborn screening that has now been around for 10 years in North Carolina is that genetic counseling comes along with that from somebody who is specifically trained in genetic counseling, maybe doesn't have much of a background in CF, but can talk about, can speak to genetic conditions and can help speak to reproductive options.
See, and the unfortunate thing is, and I don't know what the right, and I'm just me, because, like, we saw that, like, I also have a daughter who was born after my son, and a genetic counselor, yes, we saw one, and they're fabulous because I work with many, and however, you need something more.
Right, no, but so then the idea would be that it bridges to your CF team to continue that conversation. So what we all know is that, like many topics that are sensitive, we as clinicians tend to wait for you guys to bring them up, which is not appropriate, right? We know this. There are lots of reasons that happens. A lot of it is our own hesitation to talk to you about serious things that affect your lives that we know would be hard for us to cope with. But part of what we are, what we need to do, what our obligation is to make space for those topics. Some people don't want to talk about it, right? Some people aren't ready.
I just didn't know if they were having any more.
But there isn't a good
in the big CF
way or protocol. The idea is that that genetic counseling visit bridges with a conversation with the CF care team early, and it opens the door for that to be readdressed. But we don't have a structure where we say annually for families who have, you know, where parents are of reproductive age, we bring this up again, or something like that, and we should be. And there may be people developing resources that would help facilitate those conversations, but it wasn't highlighted. But it's a really important thing to, and thanks for, it's on my list for us to be thinking about in our quality improvement group.
The referrals to the genetic counselor, I don't remember.
So they have not had a good system for that
but like,
at UNC. Yeah, we just have not. So it's been, that actually came up again recently as a, why are we not doing this?
Say from my experience, UNC, where my first one was like and it's been the first 4 weeks, with no other options. And then when we went for our 6-week follow-up, so I don't know too if like, you know, like this is thing that was one of the first things that came to mind.
I can remember, like, and that's come so long, because I remember, I can even name the guy in Australia, like, I hunted that down, PGD, that was so new back in the day, and so I'm glad that that's even, like, being brought, you know, in those.
It may depend on who you see in follow-up, though.
Right.
Whether they think to bring that up, right?
Yeah. Not you. Wasn't it?
No, but
yeah.
I'm not sure you don't
Right.
with it.
But we weren't presented with that, you know, in our first visit. But do you remember hearing about that?
I don't remember anything.
So that's the thing is that it often comes up, but it isn't, there isn't a lot of attention to it. And at a newborn screen visit, and many of you obviously have kids that were not diagnosed by newborn screen because we didn't have it back then. But at the first visit where we kind of spew a ton of information about CF, a part of it is supposed to be counseling about genetic condition, and that if you are considering having more children, we need to talk about, you know, your options for knowing in advance whether you might have another child with CF, or deciding that you want to use reproductive technology to not have another child with CF. So I think it's, a lot of it is dependent on who has that first conversation. And I would say that I always bring it up, but I try to read the room, and I don't push too hard to continue that conversation. We have people, you know, parents we're meeting with who are like, well, I already read about that, and let me tell you, I have these questions, and they're like all over it somehow at that visit. But much more commonly, that visit with your, when you're sleep deprived with your 3-week-old baby, very different, and people aren't ready to kind of absorb that information. So it should not fall off our radar. It actually occurred to me that we have guidelines for sort of the first year of care, and it's not on our visual map that we check to make sure we're doing all the right screening stuff. It's in the body of the article, but it's not there. That's highlighted.
on the CF website, CF Foundation's website, I don't think they address it. I mean, I guess they're focused on CF patients, not like family or like that, the thing that.
You know, it's interesting because I think some of it is embedded in the reproductive education for people living with CF, right? So if you
I wouldn't have clicked on
want,
that.
nope, because it doesn't apply to you. That's right, it applies to your child, not to you. So it's not as helpful, for sure.
I just remember doing like a lot of notes on that, you know, when they first did that.
Yeah.
And having a that partnership with your provider is so key too, because I don't think I'm not easily openly share that with you, bring it up. But if it were different, I didn't have that same rapport with the provider like I do you, then it might not be as easy to bring it up. And
That's good. I was hoping that they brought up at the conference and had something, you know.
And it may have been in a session that I wasn't here for, but it also is something that tends to, there are a lot of kind of small group meetings that are kind of by profession. I mean, you know this because you've been there, right? But there probably were roundtable, small conversations about these things, and it takes a while for that to get out. I will say that, you know, having now worked much more closely with the CF Foundation. I did not understand much of how it operated for a long time, but I have seen directly in the last couple of years how much work is being invested in just practical information about living with CF and trying to make things accessible and trying to help people who have different levels of understanding and interest and desire to know details have better resources. So there are many, many things that are under development and revision. And I think ultimately all those areas will at least be covered with the goal of standard information that everyone can have access to, right? So if you have a clinician who happens to be very open and very well versed in things, and you're comfortable with that, fine, you may not need any of it. But if you have someone who really doesn't bring those things up, or you're not comfortable talking with them, you should have some basic information, or at least it empowers you a little bit to ask the questions that you have.
There's no more questions in the room. I'll ask
You had a general,
question. Ready? Do you believe a cure will be discovered in our lifetime?
Oh boy. I hope so. I hope so. I think it's a lot more likely that we'll have such good therapies that we won't have to really think about, at least for a long time, right? We will have to be dealing with the downstream effects of CF and how hard it is to live with it. But my sincere hope is that we will. But I think it's more likely that we'll have just better ways to treat it, right? And you know, we've been waiting a long time for a cure. It's a tough problem to address. But you guys are amazing.
Right, you're not
And I love your children. I'm so grateful for the opportunity to work with them and with all of you, to watch them grow up and do amazing things. It's just really cool. So we appreciate that. And we are all holding our breath for it to be so much better than it is even right now.
Thank you very much. Thank you so much, Elisabeth. I'm so glad that everybody came out today. Annie for the host too.
Yeah.
Really.
Yeah, that's right.
You know, food and
Yeah.
a wonderful space to do this. And everybody has my email, and any topics or thoughts or for future sessions. We had talked about a parent who is involved in the Family Advisory Board, went to the CF conference this year, we sent. And so we're hoping maybe the next session that she's going to come and kind of from a parent perspective, what she got out of the CF conference. I don't know, have you talked to Kristen about?
I saw her last week.
Yeah, I think it was last year. Earlier.
I don't remember.
Yeah.
Recently, and we
It was
didn't
a
talk.
CF
Yeah, at that meeting.
Yeah.
We didn't discuss it. But I mean, we have the holidays, so we probably won't. Right. So if you have thoughts about that, and I know that Mike and I had talked as well, and our Family Advisory Board has been a little bit on the not meeting regularly.
Right.
I think the momentum has lost, and we're trying to build that up a little bit. So if anybody is interested in being part of the Family Advisory Board, or kind of has thoughts about quality improvement projects or things that we could be doing better in clinic and information, I know one of our big quality improvement projects we're working on is transition planning, and we're going to try to encourage some of our adolescent and young adult CF patients to be involved in that, kind of calling into some of our QI meetings and giving their feedback of how we're doing and what we can do to it better. And I know that there's a lot of things we can do better about that, and we would love to hear from them. So if you have older kids who are interested in that, please let us know. But Mike, I don't know if you I just wanted to, while we have a group of people here too, talking about Family Day. I know we didn't have one last year, and
Yeah, we were thinking about having it maybe in April of this year. So tentatively pencil that in.
yeah, and even if people aren't involved in on the Family Advisory Board, but if you have some ideas, if we do have a Family Day, of some topics or speakers or
something that you would think would be a draw or bring you in for that, please send any suggestions, ideas, thoughts. Either send an email, or when you're in clinic, you can tell us. You know, Duke does have a family day. They had one last year. I think it was a shorter half day. I think they had food trucks and yeah. Yeah, that would be.
Absolutely, and yeah, there's been a lot of cross-pollination because we were helping cover their clinic for a while when they had a little outflux temporarily of pediatric pulmonologists, but they've actually had an influx of UNC trainees. So two of our research fellows are there. Those of you know, if anybody knows Matt Rule or Laura Sozier, they're in that part of that team now. But the CFTR team, the core team at Duke, stayed throughout kind of that transition and are, have been doing great work for years. And it would be really, I agree, it would be kind of a cool thing to bring together.
Definitely, and even in Greenville, where, we have a lot of shared patients, and they're kind of growing as their own center, and I think we have, we advertised with their CF families as well, so we could.
Is anyone on the call? Do you know everyone on the call?
The what?
Is everyone on the call tonight? Do you know everybody? Because this went out to Wilmington and to Charlotte too. I'm just curious.
Yeah, and I believe Jacqueline, who had a question, I think was from Greenville.
And everyone.
Yeah.
Charlotte has had a big kind of change in their program structure as well in the past year. So there's, just lots of new things going on. So also, those of you who know, kids who are all there, we're all learning. We actually, as clinicians, talk quite a bit because we do have kids that are seen at both centers, or, we will reach out about different things based on, things that we know happen at one place or the other. So there's a fair amount of communication among clinicians, and I'm assuming a fair amount of communication among parents, but it's nice to really build those networks for sure.
Thank you.
Everybody.
And thanks, Jennifer, as well, for getting this going and all of your work on it. Right. Well, thanks everybody for
doing everything for WebEx.
I know. Thank you very much.
Yeah.
So I think we successfully recorded this time.
Great.
So, yay.
It's recorded, so I